Hi everyone, welcome to our second session on data interpretation. Today we have Mariane with us, who is a fifth-year medical student. She has kindly given up her evening to give us a tutorial on how to interpret chest x-rays.
Yeah, thank you for the introduction. And so, hi everyone, my name is Mariane. Nice to meet you all. Please, during the whole tutorial, don't hesitate to write in the chat. Nothing is too, there's no silly questions. And if I'm asking a question, there's no silly answer either. Just give it your best try. It's really informal. It's all about helping you guys, so don't worry. So the talk today is about interpreting a chest x-ray, and we're going to talk a little bit at the end about presenting as well, if we have time. Just want to credit the people who helped me make these slides, which are Joel and Shubham. So we made the slides together, but I'm presenting today. So the aims and objectives are to gain a better understanding of chest x-ray interpretation and to learn a systematic approach to interpreting a chest x-ray. Because it's really easy to look at a chest x-ray and forget, where to start or how do I do it. So it's good to have a system in your head of what exactly you're going to go through, and that way you won't forget anything, right? Perfect. So the plan is we're going to talk about the systematic approach and at the same time some conditions to know about. So for this lecture, I'm assuming that you remember a bit of anatomy, not too much anatomy, just a bit of anatomy, and we can chat about some conditions that affect the lungs. Then we will have a short quiz, and then we can talk about presenting chest x-rays, all right? Again, if you have any questions throughout, just post in the chat. Right, let's get to it then. Okay, so as we are, doctors are always on a little investigation. So how are we going to investigate a chest ray? The first thing you do, as always, what do you do when you see a patient, when you see a report for the first time? You need to check the patient's detail. That's really important. The name, the date of birth, and the hospital number. Because essentially, am I looking at the right patient? Otherwise, you're going to make some very bad clinical decisions, aren't you? And then you want to check the date and the time that the film was taken. When I say film, I just mean the X-ray, right? But these are some technical terms for you to learn, okay? So you want to be looking at the right film, because if you look at the film from 2 years ago, it's not going to give you any information about how the patient is doing right now, okay? So that's obvious, but it's really important to always say, right, I'm looking at the right patient. So you might want to look up some previous imaging, that X-ray from 2 years ago, because it might be useful for comparison actually, right? And if you can look at why the doctor requested this X-ray, this might actually guide you. For example, the X-ray was requested because 3 months of a cough or something, 3 weeks of coughing, and then that's why the X-ray was requested, okay? So that was step 1. Now, step 2. Check the image quality. So it's an acronym called RIPE, okay? And this stands for rotation, inspiration, projection, and exposure, okay? So rotation is literally, is the patient rotated or is he straight ahead looking at the camera essentially? And for this, the medial aspect of the clavicle should be at the same distance from the spinous process. The spinous process is the center of the spine, right? And the clavicle is this bone here. So the medial aspect of the clavicle, I'll show you on the next X-ray that we see, it should be equidistant from the spinous process. Inspiration, there should be 5 to 6 ribs visible. And projection, that's the important one I'm going to talk about on the next slide. It can be anterior, posterior, or posterior, anterior, okay? And exposure, which is the same thing as penetration, it means that you should be able to see the vertebra behind the heart, but not too much. If you just see the vertebra, then you can't see the soft tissues. It's too much penetration, right? And also, it also means you need to have the right sort of like frame around the X-ray, because if the X-ray stops too high and you don't have enough frame, then you can't see it properly. So this is just to check the image quality, but don't worry about this too much because the X-ray departments will also check the quality of the image. So you don't have to worry about that too much, but it's worth, mentioning it, I think this X-ray might be a bit rotated, so I'm not sure, mention it if you think so. Right, projection is the really important one I want you all to remember. It depends where I keep on saying the camera, but there's a little device that sends the X-ray, right? And then there's a screen, which is where the X-ray will print onto the screen, okay? So if the little X-rays are sent through the back and they are printed on the front, as you can see the screen here on the front, this is called PA, posterior anterior. The little X-rays come posteriorly and they will land on the film, okay? This is really good because you can interpret the heart size, because the heart is really close to the film. So it means that you can properly see the heart. Whereas the other version is anterior posterior. So it means X-rays coming from the chest and it's printing on the back. The screen is at the back essentially, okay? And as you can see, because the heart is far away from the screen, it's very blurry. So, so you can't really see the heart that well. And the heart will be magnified. It will look a lot bigger. So you can't interpret the heart at all if you're doing an AP chest X-ray. However, you can still look at the lungs and the lungs will be fine. So the most commonly done is the posterior anterior and the less commonly done is the anterior posterior. But it might be useful if a patient cannot stand upright because we can do this one lying down. So we can actually do it, if they're ITU, in ITU and we want to know if they have a pneumonia or not. We don't have to get them up to the X-ray department. Just bring the film, bring the little X-ray device, and it's done in like 5 minutes. So it's really useful for those patients who need to lie down and they can't make their way to the X-ray department. So if you're interpreting a film, if it doesn't say, it's PA, okay? Otherwise, it'll say, okay? But it's worth, if you don't know, it's worth just checking, oh, is this a PHS X-ray? Right. Another tip is that the clavicles go downwards in PA, as you can see on here. The reason why is because when the patient is standing, they ask the patient to lift their arms up like this to have a good view of the chest. So the clavicles will go downward, whereas when they're lying down, they're just lying down. Great. Now move on to step 3, which is the real interpretation, the real detective part, okay? And it's an acronym that is ABCDE. And we're going to go through it right now. So it's airways, breathing, cardiac, diaphragm, and everything else. I know I hate the everything else part because it doesn't help you, but there's actually two things in there, so don't worry. And the last thing before we delve into it is, on an X-ray, everything that is dark is less dense, like air, okay? So everything you see that is dark, that is black, it's air or it's less dense. And everything that is white is more dense, so fluid and bone. And bone will be even whiter than fluid because it's even more dense. So you get a gradient of different grays and whites and blacks, right? So remember this whenever I ask you, what is this, gray blob? You have to know that, is it more dense or less dense? Great. So airways, the first thing that you do is check the trachea, all right? Is the trachea midline? Is it significantly deviated, okay? And that's very easy because the trachea goes down. If it goes down at an angle on the X-ray, you can see it. It means deviated, okay? So if the trachea is deviated, you have to look for what is causing it to be deviated. Is there anything that's pushing it or that's pulling it? So I have this little table here. I'm not going to talk about it for too long, but if it's something that can be pushing it is away from the lesion, that can be a large pleural effusion or a tension pneumothorax, okay? And something that will be pulling the trachea is towards the lesion. So that can be a lobar collapse or, pneumectomy or something like that, okay? So it's the first thing you see. And if the trachea is deviated, it's really important. So make sure you make a note of it. So here, the trachea is very mildly deviated. It's not too bad, but it is deviated, okay? And obviously, what is the cause? It's this large white shadowing on the left side of the field, right? So you can see, you can't see the heart, it's just white shadowing. So there is here a pleural effusion, okay? And it is pushing the trachea away, okay? Any questions? Right, so remember this sort of image in your head, you see? It's completely white out. It can't be a pneumonia that's that big, okay? It has to be a pleural effusion. It starts from the bottom, fills up. Okay, so airways, we said, is the trachea midline? The second thing is we will look at the bronchi. Are the bronchi visible? Are there any masses? Okay. And then we'll look at the hilum. Is it symmetrical? Are there any masses? I've grouped these two together because you can just look down at the bronchi and the hilum, okay? The hilum is where the bronchi actually arrive in the lung, okay? And it's really important because there are many lymph nodes in the area, and lymph nodes, they should not be visible, okay? If they are visible, then it can mean some problems, right? Unilateral lymph nodes could be indicative of a malignancy, whereas bilateral, it's usually sarcoidosis, okay? Right, so what can you see on here? You can see lots of shadowing around the hilum bilaterally. So it potentially sarcoidosis, okay? It can't really be it's not a malignancy because it's not a unilateral lymph node, right? Does anyone want to say in the chat, what is wrong with this X-ray? Like, what's going on here? Why is it all white? If anyone wants to post in the chat. It doesn't look the same as the previous one. Oop. It doesn't look the same as the previous one, does it? It's very white. What is wrong with this X-ray? So actually, this X-ray is underpenetrated. That's why it's all white. Can you see the vertebra behind the heart? Not at all. It's completely white. So this is what we call underpenetrated X-ray. And when we get this X-ray, we might actually say, is it possible to do another one, to repeat the X-ray, because this one, the quality is not optimal, okay? Any questions at all? Right, so we've done airways. Airways was trachea, bronchi, and the hilum, okay? That's A. Now let's move on to B. B is breathing. And here we're gonna look at the lungs, very easy. The lungs is, this whole space, and we talk about it in, we don't talk about lobes when we look at an X-ray. We talk about zones. So you just divide the lung into thirds, and this will be the top zone, middle zone, and lower zone. It doesn't correspond to a lobe. It just, what I see on the X-ray is the top lobe, the top zone, middle zone, and lower zone. So don't forget that. Don't get them confused with lobes, because you can't see the lobes in an X-ray. You can't see it. You can see the zones. Okay. So the first question is, are there any masses or consolidation? Okay, because it says here increased airspace shadowing. This means it's whiter than it should be, may suggest a pathology. So it can be either consolidation or a malignant lesion. Okay, let's have a look at both of these. So increased shadowing, it's a very technical word to say it's whiter than it should be, right? So you can see the whole lung field, that's how we call it. It is, sorry, it shows that there is a lesion or a space of increased shadowing in the middle zone on the left, right? Can you all see there's a red arrow? And it's very well circumscribed, it's round, right? So this would probably be a lung tumor, okay? It can't be a pneumonia that's this round. What else can you see? You can see the heart is fine, everything's fine, okay? But there is this lung tumor, okay? And on the second photo, you can see it's not round this time, it's like a triangle, but again, it is too white. It's just whiter than it should be, isn't it? That's whenever there's a problem, it's just whiter than it should be. And this is called also, again, increased shadowing, but it's indicative of a pneumonia. You see how it's not at all the same as a tumor that is round. It's just, it looks like the whole triangle is filled with whiteness. So again, you can't tell which lobe it is, but you can tell, here I can see increased shadowing in the middle and lower zone of the lung, okay? Don't talk about lobes. Right, so we checked if there's any masses or consolidation. Then we have to check, does the lung actually fill up the entire lung zone, right? So you have to check that the lung markings stretch right up to the pleura. What's going on here? If anyone wants to post in the chat, because I know you can all see it. There are no lung markings at all here, can you see? Here, there's some like little filaments. It looks like little roots. And then bam, on this side, it's just completely unified. It's almost too black now. And what is this thing here? It is the lung that has actually collapsed right down to here, okay? We call it right-sided pneumothorax, and it's a severe pneumothorax in this case, right? And I can actually, this is really easy to see because it's a huge pneumothorax, but I've had some pneumothoraces which are, you can only see them here. You can only see sort of like 1 centimeter where the lung markings are missing. And you still have to spot that. You have to be able to ask yourself, wait, is the lung marking extending right up to the edge or a bit less? So always keep an eye out. Even if you see a tumor, just check, is the whole lung filled up with little markings or is it empty, okay? Perfect. So after you've finished with the lungs, you can look at the pleura. Remember, the pleura is the lining of the lungs, okay? And it's not usually visible. If there's an abnormality, such as pleural thickening, you will see a very large pleura, very thick. And that can be caused by mesothelioma. So I don't have an X-ray for it because it's a bit beyond this third year sort of things you need to know. But it's good to know that if you see something weird in the pleura, it's possible that it's an abnormality. So you flag it up to the doctor, okay? Okay, and finally, is there a pleural effusion? So pleural effusion is when there's fluid accumulating in the pleural cavity, okay? Fluid hydrothorax and blood hemothorax, okay? In this case, remember we saw that in the first X-ray, you will just see some fluid going up in the lung, okay? It might be a bit of fluid, it might be a lot, up to halfway, right? This will be very visible because it's covering the lung. Sorry. So actually, you might be able to see this fluid before you can even analyze the lungs. You can open up the X-ray and be like, straight away, you can see pleural effusion, okay? Yeah, there we go. This is completely white out. It can't be pneumonia this big, right? And you can almost see the meniscus, which is like, you know, if you put water in a glass, it will be a tiny bit like this. That's the way the water sits, right? And if the patient does an X-ray lying down, actually you won't be able to see this top bit because when you lie down, the fluid just goes on the whole part of the lung, doesn't it? And just to draw your attention, these little shadows here, you can say if you know in the chat, but what do they mean? They're actually the breasts of the patients. You can actually see the breast on the chest X-ray in some cases, not all the time, but in most cases you can see it. So you can tell this is a lady patient. Right, what's the time? Perfect. Heart size, in a healthy individual, the heart should occupy no more than 50% of the width of the thorax, okay? But you only have to interpret on PHS X-rays. Otherwise, you can say, I can't comment because it's not a PHS X-ray, okay? And if it occupies more than 50%, this suggests enlargement, cardiomegaly, which is seen in heart failure. So you can see here the heart is huge, okay? And what else can you see here? If anyone wants to see in the chat, just fire away. You can see some little probes here. These are actually not in the patient, they're on the patient. These are ECG leads like this, not ECG. ECG leads that are on the patient like this. You know when you monitor a patient in HD or in IT, you have permanently on their chest some little the ECG leads. And then here you have a pacemaker. Oh, as someone said it in the chat. Yeah, pacemaker, very good. Oh, I hadn't seen, someone also said exposure earlier on. Great job, guys. So the pacemaker. And you can see the little wire going into the chamber of the heart. One wire goes into the atrium, and one wire goes into the ventricle, okay? You can learn about pacemakers in another lecture, probably. Yeah, just a red arrow to really highlight how large this heart is, okay? Cardiomegaly, heart failure, it makes sense because they have a pacemaker, so they're trying to make the heart pump again, but it's not really, you know, it's failing. So you need to look at the heart borders because the heart should be well defined. It shouldn't be blurry. If it's blurry, it means there's actually something next to the heart, like consolidation, and that will make it blurry. So you should always have well-defined borders of the heart. So you see how smooth the border is here? You can trace it right down, okay? It's not fuzzy, it's clear borders, okay? And mediastinal contours, that's the last thing for cardiac. It's essentially the big vessels. I'm not going to dwell on this because it's not as important, but you can see the aorta and the aortopulmonary window, which is this mini triangle here that is a window between the aorta and the pulmonary artery. It's important because if you get an aortic dissection, this window might be gone, okay? Hopefully you would do other tests to image an aortic dissection, but this can actually be quite useful, okay? Aortic dissection is when the aorta opens up and fills up with blood, okay? So it's really severe emergency. Okay, and also in the mediastinum, there can be lymphoid tissue and lymph nodes again, where pathology can occur. Okay, A, B, C, D, E, we're now on to diaphragm. What are the structures underneath the diaphragm? On the left, there's the stomach. Can you see the bubble here? There's the air, the air is in the stomach, that's normal, that's fine. And on the right, there's the liver, okay? The liver is slightly higher, so it's normal that the right hemidiaphragm is elevated in comparison to the left, okay? But the diaphragm should be stuck on the liver. There should be absolutely nothing in between. Here, there's some air in between. Can you see? You should not see the diaphragm on the left because it should be stuck on the liver. They should be fine. You shouldn't see any space between the two. However, here, there is some space. It has been lifted off by some air. And this can mean bowel perforation, which is also an emergency. So please always check the diaphragm, okay? We also need to look at the costophrenic angles. Costophrenic means the angle between the ribs, that's costo, right? And phrenic is the diaphragm. So the angle between the ribs and the diaphragm should be a very defined acute angle, okay? If you have loss of this acute angle, it's called costophrenic blunting, and it can mean that there's fluid, just a tiny bit of fluid. Imagine the fluid goes up to here. You would say, oh, this doesn't have a acute angle, what's going on? And actually it's just some fluid secretly seeping out, okay? So just keep an eye out for that. Or otherwise, it can mean that there's too much air in the lungs. There's so much air that the diaphragm is flattened down completely. That's called hyperinflation. And then you lose this dome shape, okay? So this is an important slide about COPD. Hyperinflation, you can see there's too many ribs here. Look, how many ribs can you count? 1, 2, 3, too many ribs. And you have a flattened diaphragm. You've lost the dome shape completely, okay? And you have costophrenic angle blunting. In advanced COPD, they might have some pockets like they call them bully, which are like big sort of like round pockets in here, okay? And also if they have early COPD, it might not show anything at all. They might have a normal X-ray, which is good in early COPD. Right, and everything else, I promise you there's not too many things in there, but make sure you check the bones. Are there any abnormalities? Because if there's a like metastasis on the rib, you should be able to see it, that would be good. And if there's a fracture, the doctor wouldn't give you an X-ray with just like everything's fine on the chest, but actually he has a fracture in the arm. But one doctor did that to me and I was completely thrown off, so. But he wasn't expecting me to pick up. He was just like, this is an interesting X-ray. What do you think? So yeah. But this is important in the context of trauma, because let's say you have a car accident. You take a chest X-ray and you need to see, are the ribs broken? Because the ribs can perforate the lung and create pneumothorax. So if you see a pneumothorax, make sure you look at the ribs. Are they fractured? Because if one rib is fractured, that can be the whole reason of the pneumothorax, okay? Okay, and any other abnormalities, for example, a large hematoma, okay? And make sure you pay attention to the history as well for these. If they tell you the patient's coming in after a car accident, make sure you check for fractures and hematomas, okay? And finally, we've talked about pacemakers, we've talked about ECG cables. Artificial valves are something that you can really see very well in X-ray, especially, artificial valves, not like, replacement with other mammal tissue. Artificial valves you can see very well on X-ray. Something else that you can see is a nasogastric tube. So when they feed patients on the ward with a little tube going down their nose into their stomach, they always ask for a chest X-ray to confirm that it is safe for feeding. Because if you accidentally put if you put it through the nose and you accidentally put it in the lung, you don't want to be feeding the patient in his lung, okay? That's a never event, So every time someone puts a tube inside the patient's stomach, they will always check with a very quick chest X-ray to check that the tube falls in the stomach and it doesn't fall in the lung, okay? Because at the end of the tube, there's a little spot on it that is radiolucent to make sure you can actually pick up in the chest X-ray, okay? So just to wrap up and also give you a second method, because we all have different methods of learning, and some people, they might go like A, B, C, D, E in their heads, and that's fine. But some other people, they might like to just visualize it in their head. So you can start by, I call it going on a journey down the lungs, right? So you start at the trachea, you go down, and then bronchi, don't forget to do each side. Then the lungs, again, don't forget to do each side, all the way to the edge, okay? And then check the pleura, and then check the diaphragm, costophrenic angle, everything, okay? And then check the heart, okay? Does that make sense? Right. Perfect. I think we're going to... Oh, yeah. If you have any questions, feel free to put them in the chat. I haven't seen anything yet, but again, if you like the ABCD method, great. Otherwise, you can go on a journey down the lungs, which I find quite visual, so that sometimes can be helpful. And don't forget, at the end, it doesn't say here, but everything else. So check the bones, check the soft tissues, okay? Right, quiz time. So I really need you guys to be interactive for this one. So either private message me, then no one can see it, and that's fine. Or you can just post it in the chat. What do you think this X-ray shows? I'm gonna give you 30 seconds. I'll have a drink. Yeah, keep those answers going, guys. A few more seconds. And when you're looking at these chest x-rays, I want you guys to also remember about everything else. Like, obviously there's this white thing here that you're like, oh no, what's going on? But don't forget to check everything else, right? Like, check the heart, does it look okay? Right, so let's reveal the solution. Yes, correct, pleural effusion. So well done the guys who got that. Yes, on the right side, because remember this is the right side and this is the left side of the patient, okay? Cool, pleural effusion. I just put here, this is more for you guys later, but this is a short history of what they might present with, which I think would be really useful for your end of year exams, being like, okay, he has a pleural effusion, reverse thinking, what did he present with, right? On examination, stony dullness, that's clearly pleural effusion, okay? If it's dullness, you don't know, but if it's stony dullness, they'll tell you that's very textbook for pleural effusion, okay? Reduced breathing sound. Of course, you can't really breathe here because it's full of fluid, okay? So reduced breathing sounds in the basal region. Right. Move on to the second one. I'll give you guys 30 seconds. There's a lot going on here, so put everything in the chat. Yeah, come on, guys. Don't hesitate to post in the chat. There's more than 2 of you in here. Right, so for the sake of time, right, lots of things here. Okay. So let's see. Yes, malignancy, that's correct. So what do you see here? There's a lot going on, right? A few of you said tumor. Someone said looks weird. Yeah, it does look weird, isn't it? What is it in the top right shoulder? Someone asked. In the top right shoulder, I don't see what you mean. I think it looks fine. Right shoulder. So here, there's a big abnormality, clearly. Increased airspace shadowing, massively. So it could be tumor, definitely. It could be a pneumonia, or it can be a pneumonia around a tumor, because tumors, they love attracting pneumonias around them. So actually, it could be more complicated than that. It could be the tumor has pneumonia around it. But as far as you're concerned, the main abnormality in this X-ray is there's probably a large tumor here, and possibly some metastases on the contralateral side. Okay. Here metastases, maybe here a lymph node. And also you can see the patient's breasts again, and also it's a bit underexposed because you can't see the vertebra behind the heart, right? Okay, so sorry, let me go through the answers again. Those of you who said tumor, that's right. The one who said pneumonia, that's not wrong. I think because there are different lesions in random places, that really looks like a metastasis, doesn't it? Because you wouldn't have just pneumonia on a randomly small metastases in the corner. You know, it's a small spot of something. It sounds a lot like a metastasis. Okay, you'd be quite worried. But so well done for you guys for tumor and pneumonia. That's different. Definitely some differentials. So once you get the history, it's very easy to piece everything together. Lost about 3 kilos of weight, not intentional, more tired recently. She quit smoking 4 years ago, but she smoked since she was 16, so yeah. Very likely lung cancer. Oh, okay, right, very easy one. If you want to tell me what's going on with this one. You can see the bronchi very well here. Yeah, someone says, wow, and I'm like, yeah, it's rather large, isn't it? Yeah, it is cardio, yeah, let me check. It is cardiomegaly, yeah, it is heart failure. Do you know the symptoms of heart failure, which is, swelling, difficulty breathing, etc.? So, yeah, he has ankle swelling on both sides, okay. Shortness of breath. Yeah, moving on for the sake of time. Okay, what's going on with this one? Oh, this is a nice one. I like it. I think you guys are gonna like it too. Yeah, the last one, sorry, the last one was very easy, wasn't it? Cardiomegaly, sorry, it was kind of an obvious one. Okay, so I'm getting lots of very good responses here. Blurry borders. Yeah, it's a bit blurry. Yeah, okay. COPD. Yeah, ECG leads, very good. Right, so a lot of you have gotten COPD. Why? Because the diaphragm is flattened. So if someone wants to say diaphragm flattening, loss of costophrenic angle, great job. I haven't seen that yet, but yeah, too many ribs. Right, there's something else that you guys haven't spotted. I knew I was going to trick you guys with this one. This one is quite hard. In comparison to the previous one, which was really obvious, this one is a bit hard. So I'm just going to wait a few seconds to see if anyone sees it. Make sure you go down through everything. So go down A, and then B, and then C. NG2, I don't think so. I think it might just be a random cable. He seems to have lots of cables going on. So diaphragm, we said he's flattened. Pleura, something with the pleura. Is there something with the pleura? All right, I'm gonna stop. I'm enjoying this, that people are thinking about this. Thank you everyone for just participating. I really like it when you guys interact. Okay, so actually the aorta looks fine. There's a very nice aortic window. It doesn't look like a triangle. It looks like a crescent almost. But you guys haven't seen the pneumothorax here. Can you see it? Can you see my mouse? You can, right? So can you see on the right side, there's a small area at the bottom in the costophrenic angle where there's no markings. And then very sly, you can see the lung border right here. Okay, are you guys happy that you're seeing the pneumothorax? You guys can't see my mouse, right? Oh my God, now I'm having doubts. Great, perfect. So you guys have seen, remember to keep your eyes out, because the pneumothorax I showed you at the beginning was obvious. It was like the lung was completely shrunken. But here is very snaky. But actually, when you think about it, it's not that small. It's at least 3 centimeters. So you would want to do something about that pneumothorax, even though it's not completely shrunken. It's quite still 3 centimeters, okay? So keep that in mind. That will remind you to always, even if you've noticed something wrong, like COPD, definitely, remember about the pneumothorax, okay? In fact, COPD makes you more likely to get pneumothorax, so it's totally makes sense. Yeah. very snaky. Perfect. Right, what is this one? What's going on over here? Okay, someone is asking, is it collapsed? So I think I can see so I think it's a bit underpenetrated at the beginning. It's very white, isn't it? So it's might be a bit difficult, but I can see the lung markings up to the edge. So I'm quite happy here that the lung markings are extending up to the edge. Someone said, yeah, I'll give you guys a bit more time. Yeah, so someone who said pneumonia was correct. So I think at least I always need to double check. Yeah, perfect. Do you see this sort of big triangle? It looks definitely like there's something there in this triangle that is just whiter than it should be, isn't it? So this we can see in the right middle zone increased opacity that is likely to be pneumonia. Okay. What's really important is that we can see some things here, but we're not quite sure what they are. So whenever you diagnose someone with pneumonia and it's a bit suspicious and they're old, make sure that when they don't have the pneumonia anymore, like in 3 weeks, you do a chest x-ray again, because there might be a tumor hiding underneath the pneumonia, which you can't see because it's completely, you know, all grayed out. So you could see maybe this nodule is a lymph node because of the pneumonia, or actually, you know, is it a tumor around here? Apart from that, you know, continuing with everything else, heart size is normal. The heart borders are clear. You see what I mean? They go straight down. Coastophrenic angles are fine, so there's no pleural effusion. Yeah, pleural looks fine. Everything else looks fine. Okay. True. Yeah, this is a little history. Lung sounds are distance with crackles in the right middle zone, consistent with what we're seeing here. Perfect. Ooh, this one is quite bad. It's quite tricky. This is a bonus one. So if you guys don't get it, that's fine. It looks like it's like this cotton wool everywhere, doesn't there? So I think if I remember well, this is a condition we haven't covered, so it will be a bonus question. What time is it? We're doing okay with time. Okay, so some people are saying infection, some people are saying TB. Good thinking. I see what it just does a lot of fuzziness everywhere, isn't there? I'd be worried if this patient had TB because it would be literally everywhere. And again, he has lines from a sort of ECG machine, a 3-lead ECG. I'm going to reveal the answer because it was a difficult one. This is pulmonary edema. So we haven't gone through it because it's more of a cardio thing than a lung thing. But this is, listen very carefully, this is when there's fluid inside the lungs, but not inside the pleura, okay? So this is the blood vessels inside the lungs that are leaking out, okay? It's called pulmonary edema. This is why everything just seems white. You look at this x-ray and you're like, why is it all white? It's because there's a lot of fluid seeping in everywhere, okay? So cotton, it looks like cotton wool. It looks mainly focused around here. There's not so much on the edge. Why? Because all the blood vessels are in the center. Sometimes they call it like a Batman appearance because it comes from the middle and extends like a butterfly. Yeah, it's just all very fuzzy. It looks like cotton wool, doesn't it? Someone said something in the chat. How do you know it's not a problem with exposure? That's a good question, but if it was exposure, it would be, and to be fair, actually, this one is a bit underexposed because can you see the vertebra behind the heart? No, you can't. So very well pointed out by this person in the group chat. I'm not too happy with seeing the vertebra that well behind this heart, so it's probably as well underexposed. But if it was underexposed, it would be white, but it wouldn't show some cotton wool aspect. This is very like, it looks like little bubbles all around, okay, like sheep wool even. This is definitely pulmonary edema, okay. And this is very interesting case of, she was recently admitted after having a fall and they gave her lots of IV fluids, okay, over a short time period. What happened is that when you rehydrate someone old too quickly, they don't have time to redistribute their fluid and the fluid goes straight into the lungs, okay. So remember me when you prescribe fluids to someone, just check the rate of fluids, okay. Yeah, that's pulmonary edema. So don't confuse it with pleural effusion, because even though it is fluid, fluids in the lungs, it's a very lay term, lay way of talking about it. You need to say if there's fluid in the pleura, that's pleural effusion, or if there's fluid in the lungs, that's pulmonary edema. Okay. Cool. During this whole last bit, feel free to just throw any questions. But I'm going to give you some examples of, some examples of how to present a chest x-ray, because you'll have to do that in OSCE, yeah, and you have to do that on the ward as well, okay? So when you're presenting, you go through the same order as you do when you're interpreting. So very quickly, which patient it is and how long ago was it taken. You don't have to say the date, you can say it was taken like yesterday or something like that, okay? Then very quickly, quality of film, just one word. Is it satisfactory or not satisfactory, okay? And then the main abnormality, just one word and where, okay? Or if it's normal, you just say normal. But it's important that before you go on through A to E, you say, this is the main abnormality, okay? I'll show you some examples later. And then you go through A to E and comment if there's anything else that's abnormal, okay? So this is a normal X-ray, but actually it's not so useful to present a normal X-ray because it's normal. Trachea is midline, bronchi and hilum are normal and symmetrical. There's no masses or visible lymphadenopathy. The lungs are clear. Lung markings are present throughout the lung. The heart size and the mediastinal contours are normal, and the diaphragm is normal bilaterally. Okay, just a nice sentences. If you say this, the doctor will be like, wow, this person knows what they're talking about, because they're not like all over the place. It's like bam, bam, bam. This is what I'm saying, okay? And then to complete my findings, I would like to take a history of Mrs. Jones, take a full set of observations, and perform a respiratory examination. Okay? So more interesting, this is our pneumonia case from earlier. How would you present it? I'm not going to ask you because obviously you can't. We don't have time to talk. So this is a PHS X-ray. How do you know? It's written here. Of Mr. Smith, made that up. The film quality is adequate, however, perhaps slight rotation towards the right. And then maybe the doctor will tell you, oh, actually he has scoliosis. Okay, that's fine, Or maybe he actually is rotated when they took the foot. You don't know. But you can say that, perhaps a slight rotation towards the right. And then the main abnormality is a large area of increased opacity in the right middle zone. Okay, you state it, you say it there. You don't go through your HE. You say the abnormality, and then you go, okay, the trachea is midline, bronchi are normal and symmetrical, or actually you could say there is some area on the right bronchi that I'm not sure about, might be a lymph node. Yeah, there we go. Also, you can say this can be due to the general shadowing in the area. There was no sign of pneumothorax. The heart size and mediastinal contour are normal, and the right hemidiaphragm is raised, which it is. It might be normal, but you still have to say it, you know. I can see that it's definitely raised in comparison to the other side. Overall, this area of opacity could be consistent with a right-sided pneumonia. Before putting forward a diagnosis, I'd like to take a history of Mrs. Smith, take a full set of observations, and perform a respiratory examination. Okay, so that's a good example. We have a tiny bit of time, so I'll just go through abnormal X-ray 2, which is the difficult one we had. So I think that might be just helpful for you guys. There's a lot to talk about, okay? So this is a PHS X-ray of Mrs. Smith, 60-year-old lady. The film quality is satisfactory. Yeah. The main abnormality on this film is a circular area of increased opacity in the left lung. I could even say the left upper zone of the lung. The trachea is slightly deviated to the right, away from the lesion. Okay. And there is a small circular area of increased opacity in the right lung film middle zone, about the size of a coin, okay? There is a third area of opacity on the right lung field in the top zone. So you see how this is not the main thing, but we still have to mention it at some point, okay? There was no sign of pneumothorax, heart size, and mediastinal contours were not able to be assessed, okay? It's just very blurry. Yeah. Overall, this area of opacity could indicate a malignancy in the left lung with potential metastases, and the tracheal deviation is worrying. I would urgently investigate this patient, okay? You can even say would manage in an A to E approach, because if the trachea is deviated, they're really quite unwell, okay? I didn't write it, but yeah, manage in an A to E approach. Right, summary and questions. I love this slide. I just need the main ideas. That's literally me all the time. Right. So remember, systematic approach, patient details, quality of film, ripe, interpretation, ABCDE. Okay. And the conditions we learned about were pleural effusion, lung tumor, pneumothorax, and we also learned about pulmonary edema and COPD actually, but the main ones we learned about. And then we learned to present, you have to be systematic, concise, and clear. And you have to present it in any examination station, okay?